everyone, and welcome to this afternoon's webinar. My name is Kelsey Goforth, and I'm the National Volunteer and Events Coordinator at Dying with Dignity Canada. I'd like to thank you all for joining us today. We have a really unique opportunity this afternoon that I think everyone will enjoy and find quite interesting and helpful as you try to navigate what's going on in Canada under our new assisted dying law and what you can do to learn how to plan for your own end-of-life care. Before we get started, there's just a couple housekeeping items I'd like to go over with everyone. So as mentioned in the reminder that went out, there are two ways to join the webinar this afternoon. You can either phone in or you can use your computer. So we're encouraging as many people as possible to use their computer. That way you can see us, you can see the slides, and you can participate more fully in the session. Also, the phone number provided is for Toronto only, so if you're outside of the Toronto area, you may be charged long-distance fees. So please do log in using your computer if you can, just to avoid any unwanted fees that you may accumulate on your bill. Also, I'd like to let you know that, and this was in the reminder too, while we do have physicians on the call today, they are giving general information. If you have specific questions about your own end-of-life care, it would be ideal to have a conversation with your own physician too. This is general information, but we can't provide any assessments today for individual patients. Also, we got a lot of questions from you, which was wonderful. We're so happy to hear from you and to hear that our supporters are so engaged in this issue. Given the time that we have, we don't have time to go through everyone's questions. We tried to get as many included as we can, but if there is anything that we missed, or if you think of anything extra in the next day or two, do feel free to email us. We'll also be sending out a survey tomorrow, so you can put your question in that survey too, and we can try to make sure that the most appropriate person will answer your question for you. And with that said, I think I went over everything I needed to. We will welcome our guests today. We have Dr. Jonathan Reggler and Dr. Chantal Perrot. Jonathan's joining us from Comox, BC, and Chantal is here in Toronto. And we are so happy to have the two of them with us today. They are so knowledgeable and are so excited to share with you their experiences and bring a little bit more clarity to you today. So I will turn it over to Jonathan and Chantal to get started. You can see their bios on the screen, but if each of you could tell us a little bit more about yourselves and why you are involved in this issue, that would be wonderful. Chantal, would you like to go first?
Sure. I've been a family physician in Toronto for over 30 years, and choice in health has always been an important part of my life, and end-of-life care has been a long-standing interest going back to medical school. So I didn't expect to see it in my lifetime in Canada, and I'm very pleased to be participating, and it's been quite an amazing experience so far, and I look forward to sharing some of that with you today.
Great, thank you.
So I too am a family physician. As you can see, I've been in Canada since 2003. I have always felt that people should be able to choose to have a medically assisted death. It seems to me that we make choices in our lives in all sorts of ways, and that's really no different. I decided to get involved because, to be quite honest, if I ever wanted to have a medically assisted death, I would feel that it would be wrong if I had not made myself available as a provider when I was working. And so really, because I might choose one day to have a medically assisted death, I thought I should be doing this work now. I'm incredibly proud to be involved with Dying with Dignity Canada because it's been such an important organization in actually bringing this about in our country.
Great. Thank you both so much. So we will get right into the questions, and the questions that came in, most of them were about medical assistance in dying. Not surprising, given that it's so new in this country, and there are a lot of people who want a little bit more information about what it means for them. But we did want to get started with a question that came in that's a bit more general about advanced care planning and what you can do now to try to prepare for later on. So the question is, how can I begin planning for end of life? What can I do now to make it easier for my healthcare team to follow my wishes in the event that I can't speak for myself?
So I'll start off with that one. It gives me a chance to plug advanced care planning and thinking about end-of-life care. I think we are never too young to think about it. We're all exposed to death and dying throughout our lifetimes, even when we're quite young. And a question that I ask all my patients when at first interview, including all the medical things, I ask them, do you have a will? Do you have powers of attorney? Have you thought about these kinds of things? And the older ones often will say no. The young ones are kind of surprised that I would ask, but it plants the seed and allows them to start thinking about it in relation to themselves, but also in relation to their parents, their grandparents, other relatives, and that kind of thing. The sooner you start thinking about it and have an idea of what you might want for yourself, the better. And then I encourage people to talk about it with their families, with their friends, with the people who might be involved when that time comes, and certainly speak about it with your doctor. Particularly for MAID, if you're interested in MAID, the sooner you document that in the clinical record, then the doctor, if that time comes, can look back and say, yes, this person has asked about MAID, has been informed about MAID, has been interested, and thought that they might want MAID for many, many years. And that certainly helps us in our assessments for patients. And I'll close with that.
I'd certainly echo all of that. I think actually getting things written down is important. You may change, of course, in your views, and so it's also a good idea if you have written a will, if you do have an advanced care plan, is to go back and revisit it every now and then as you age with your the loved ones and those who will be your health representatives, so that it's kept up to date. This isn't something you just do once and never again. It's an evolving thing which you should go back and make sure that it still says what you want it to say.
Great, good points. Thank you so much. Okay, moving on. So a lot of questions came in about eligibility, who is eligible, and what this all means. So we'll get started with the first one. If the patient is diagnosed with a fatal illness, does he or she have to be in serious pain or discomfort before accessing MAID?
I think it's very important to understand that intolerable suffering does not necessarily involve pain.
Physical pain.
Sorry?
Physical pain.
Indeed, physical, that's what I mean. Does not, thank you, Chantal, does not necessarily involve physical pain. Emotional, psychological pain is of equal importance, for many people more importance. Mm-hmm. The idea that they will become how they see it as a burden on their family, although that itself, I think, is something that needs to be discussed very carefully with the family. To what you mean by that. But psychological pain, psychological suffering can be very severe. And even if the person doesn't have physical pain, you can access medical assistance in dying.
Yeah, that would pretty much cover what I would say too.
Okay, thank you. Okay, if someone has a disability and wants an assisted death, would they qualify?
Somebody with a disability would qualify if they meet all the other criteria that are in the legislation for an assisted death. As having a disability doesn't automatically exclude somebody from accessing MAID.
So I think it's probably important, and I'm not sure if one of the slides later outlines what those criteria are. So the first thing is that the person has to have a grievous and irremediable condition. In other words, a condition that is incurable. And cannot be helped using what treatments are acceptable to the patient. They have to be in an advanced state of decline, and their suffering has to be intolerable. And also, because of the law, which is different from what the Supreme Court said, but the law also requires, and we will, I know, come on to this, that the patient's natural death has to be reasonably foreseeable. So simply having a disability isn't enough. You have to have the other criteria as well.
Great, thank you. And just as you mentioned, reasonably foreseeable is one of the criteria that is laid out in the federal legislation. And as a physician, how do you interpret this? How do you look at a patient and know that their death is reasonably foreseeable?
This is probably the most difficult part of the law as far as physicians are concerned, because reasonably foreseeable is not a term that we are used to using. It doesn't appear in any of the medical textbooks that we learn from. It's not something that our teachers have said to us. It's just not a term used. It's a legal term, really, and often is used by lawyers, but not by us. It probably is best thought of as meaning reasonably predictable. Can the doctor, taking everything into account about this patient, predict that the person will die of their combination of problems at some point in the not too distant future? That was, the government actually published some explanatory documentation for physicians and others to consult, and in those documents they talked about, the not too distant future and it not being too remote. So predictability, taking into account the person's main illness, their other illnesses, their degree of frailty, and their age, and their life expectancy, and we have tables for average life expectancy. Then taking all those things into account, we can decide whether it's reasonably foreseeable. Now, what the law definitely does not say is that it has to be within a certain period of time. It doesn't have to be 6 months, which it does in those states in the United States that have medical assistance in dying, so it's not 6 months. We know that there are some places where they're very reluctant to go beyond 12 months, but there's nothing in the law that says that. The law hasn't been tested, so to speak, in terms of what the greatest period of time is. The Minister of Health, and I would stress here that I'm just giving information here. I'm not saying about anyone, if there's anyone there thinking, well, my life expectancy is this according to the tables. But the Minister of Health, when she spoke to the Senate on June the 1st last year, said that she was 100% certain that Kay Carter would have qualified under the new law. And Kay Carter was 87 when the Supreme Court case started, and the average life expectancy of a North American female, or a Canadian female in fact, who's 87, is 5.5 years. That doesn't mean it's 5.5 years, but it's uncertain. It could be longer than some people imagine. It means we have to look back at the other issues to do with that patient. What's their diagnosis? What other conditions have they got? How frail are they? Doctors have to take all of those things into account.
And I think what Jonathan is also saying is that this is where the art of medicine comes in as well. There is no table we can turn to, no guide we can turn to that says this is exactly how long a person is going to live with these conditions. So it's partly going to be our experience based on having examined and assessed many, many patients over our careers will give us an indication of what we think the natural death reasonably foreseeable would be. And the question can then become how to defend that if it's challenged at some point. So there's a lot of debate in the medical community about how to interpret it. Some of us are, as John was saying, much more conservative than others. I think we're all pretty assured that it's more than 6 months, but how much more, nobody really knows. And I know physicians have allowed themselves to think about and provide MAID for patients when they thought their natural death was probably a year, 2, or even 3 years out. But again, none of that is exactly predictable.
And the law does say that there is no set prognosis. It is very explicit that it does not say, that there is any particular, we call it, the doctors call it prognosis, the sort of the outlook, the expected length of time. There's no particular prognosis that it must be more or less than.
Any last comments on that, Chantal?
I think that's good. Thank you.
Okay, thank you. Thank you for your insight into that. I think that has caused a lot of confusion for a lot of people. So hearing from two physicians, I think will be quite helpful for everyone. Okay, next question. So as many of you know, there are groups of people who, under the current law, do not qualify for an assisted death in this country. Those are mature minors, people under the age of 18, people with mental illness as the only condition or the condition that they would, you know, ask for an assisted death because of, and also those who would only be able to access an assisted death if they put in an advance request to have an assisted death. So three groups that currently cannot access an assisted death. So this person is wondering if there's any updates on what that is looking like, if we know anything more about what the federal government's thinking in terms of moving this process along.
So I think at this point we don't know much more than has been out recently. The federal government has launched, I think, 3 panels to look into these 3 different groups and to provide recommendations. And I think the recommendations or their feedback is due sometime at the end of 2018. So at this point we have nothing really further to report.
As Chantal says, the Council of Canadian Academies has been asked by the government to report by the end of 2018. Unfortunately, and as everyone listening or watching today is either a member of or associated with Dying with Dignity, and therefore perhaps keen that this should be done very well. Unfortunately, the panels have been told that they're not to make recommendations. They are simply to examine it and then present the results of the examination to the government. I think Dying with Dignity and other organizations will probably themselves also make recommendations around about that time. I would imagine that many people here feel that mature minors should be able to request a medically assisted death if they're old enough to make that sort of decision, and they're old enough to make, they're mature enough rather to make that sort of decision. The other issues are probably more contentious, and I think that we should look forward to everybody, including ordinary citizens, making their views known about whether or not mental illness should be the reason for having a medically assisted death, and the role of advanced consent too, which is a very difficult issue by itself.
Thank you. Okay, so the next chunk of questions is about interacting with your healthcare providers, specifically on the topic of medical assistance in dying. We'll get into the first one. So this is about access, and as many of you know, access has been an issue across the country for a lot of people who are trying to find providers to speak with them about their options for end of life. So how do you find a physician who is providing MAID? Does this vary by province?
Well, the short answer is that it does vary by province, and each place is going to be different, and it's an evolving process as well. For those in Ontario, we have just launching tomorrow a new care coordination service that the Ministry of Health is launching so that people can actually self-refer. Up until now, there's been a registry of physicians who are willing to provide and assess for MAID, and somebody's physician could contact this registry and then connect the patient with a willing physician. But now anybody can call this new registry and get referred to a physician. Here in Toronto, we have a website called GTA MAID, and patients can go to that and get a referral to those of us in Toronto. You can go through your family physicians, specialists, hospitals. There are various means to get to it. The surest way has been either to go through Dying with Dignity or through the Ministry Registration Service. And I think across the country there are various numbers that people can call and organizations who are managing the access to care, but it's not even across the country. Maybe Jonathan can speak a bit more about what goes on in BC.
So in BC, we have a number of health authorities, each of which manages access itself. For example, here on Vancouver Island, there's a website. Vancouver Island Health Authority has a website for MAID. I think probably as a sort of a general answer, I think good old Google is actually a really good way of finding out how you would access it in your own community. So just putting in medical assistance in dying, and then the city or the area, if you happen to know what the administrative health organization is in your area, just put in medical assistance in dying, and I would put in Vancouver Island Health Authority, or if I was over on the mainland, I'd put Vancouver Coastal Health, and you should be able to find the web page for your organization. It does vary very much province by province and area by area, but that sort of approach should work. And even if you can't find the name of an individual physician who will provide, you will find out how your area manages that. And I would be surprised if you weren't able to end up speaking to an administrator of such a system, after a relatively brief search. Now, that's not ideal. Of course, it's not ideal for people who are isolated, people who don't know how to use a computer, people who don't have relatives who can help. So I'm not pretending for a minute that the system is well established and in place all across the country. But for anybody who's watching this or listening, who wants to find out, then that would be the way that I would suggest they go about it.
Well, anybody on this call can just ask Kelsey. She'll make the connection.
Indeed. Yes.
I have to say, Jonathan, in preparation for the little talk that I'm going to be giving at the conference this coming weekend, I did enter into Google MAID, medical assistance in dying, assisted death, and came up with very little in Toronto. Now, perhaps tomorrow, with the launch of this new care coordination system, that will come up. But it was, yes, I think, on the second or third page that I finally found the GTA MAID site, and only one hospital actually had any information that was available to the public. So Googling it is not so easy, at least in Ontario.
That's disappointing. I know that if you did so here, it would in BC it would work better. But BC has, for one reason or another, been quite at the sort of the front of the of developing medical assistance in dying across the country. So yes, I guess you're right. I mean, for anybody listening here, Kelsey and the rest of her team are the people to go to if you can't find the information otherwise.
Mm-hmm.
Yeah, thank you for bringing up that point. And I think we can see, just looking at your experiences in Ontario and BC, that there are many differences, and that's going to be different in the Maritimes and the Prairies as well. So it is quite a patchwork at this point, with some authorities and some ministries and some hospitals taking more of a lead and others stepping back a bit more. So yes, if you do struggle at all to find out about next steps or where you can find a physician, please do get in touch with us, and we're happy to connect you. Go ahead, Jonathan.
I would also say that although again it varies province by province in terms of what physicians must offer patients in terms of information. In Ontario, for example, physicians who are conscientious objectors are required to make what's called an effective referral to somebody whom they know would provide medical assistance in dying, or to an organisation that would arrange that. In BC and other provinces, they're not necessarily required to make an effective referral, but they are required to give the person information. So even if your own physician is adamantly opposed to medical assistance in dying, or says that you don't qualify, or it's too early, they are nonetheless required to give you information that allows you to access the local system. And if they don't know, even if they're a conscientious objector, in my firm opinion, it's their job to find that information and give it to you. And I would be very surprised if the College of Physicians and Surgeons in whichever province that is would feel otherwise. They would say that it is the doctor's duty, if not to make a referral, to at least provide you with the information.
Anything to add, Chantal?
No, that's fine. Thank you.
Okay, thank you. Okay. Okay, so we discussed, we started off the webinar today with, conversations with healthcare team and planning, but this one's more specific to MAID. A lot of people wrote in and said, I don't know how my doctor feels about MAID. I don't know if they're supportive or not. I don't know how to bring this up. So they're just asking for some tips. And as a physician, if somebody is considering this option, what should they bring to the conversation when they come to meet you in your office? Is there a certain way they should begin that conversation? Do you have any tips to help you sort of build that relationship and have that discussion to begin with?
I always think that being upfront and straightforward is the best policy, and to approach the doctor, say, I know this thing called medical assistance in dying exists, and I know that it's legal in Canada. I'm thinking that's something I might like for myself at some point, if you're not sick at that point, then to raising it in that way. Or if you are ill and saying, this seems like a really good thing for me. What do you think, doctor? What would you support me in this? What can you tell me about it? And just open a general conversation. I will say that I've had a range of responses when I've talked to patients that I've seen over the past year, some who have raised it with their family physicians or their specialists, and they have been shocked at the negative response that they've gotten. So you're right, it's not always going to be a positive and friendly conversation. Some people can be quite chastising, quite negative, quite accusatory in their responses to patients who, to my mind, deserve only to be have their questions answered and be treated with respect, but that doesn't always happen, and so there's been quite a bit of suffering that's been caused as a result of that. But these people are your physicians, and they have access to your most intimate parts and your most intimate history, and they're there to care for you in your vulnerability. And if you have a physician who will not talk to you with respect, I hate to say find another physician, and I know that that's not easy, but it's a very important thing for you to be comfortable to ask these kinds of questions, to have conversations about it over time, to let your views evolve, your thinking and feeling about it evolve, and perhaps even to help grow the physician if they're uncomfortable or conscientiously objecting, but to help them to grow into becoming more comfortable with the idea of even talking about it and expressing their views and helping you find someplace else to go.
I completely agree with that. There isn't anything you said there which I think is, could be put differently. I totally agree. I also think that it's actually quite, this question is about, with my physician, about maybe the implication is that it's about the person themselves. I also think it's entirely appropriate for somebody to ask on behalf of another family member. It's a more difficult conversation for sure, particularly if you're unlucky enough to have one of those types of physicians that Chantal has just described. But elderly folk who may not necessarily know about medical assistance in dying, but nonetheless it would be appropriate for them, and if they knew about it, it's the sort of thing they want to they would want to know about. I think it's entirely appropriate for their health representatives, just as their health representatives would expect to be able to talk about palliative care, terminal sedation, any other treatment. Medical assistance in dying is actually just another medical procedure, and it isn't something that should be regarded by the medical profession as off limits for other family members to discuss. Of course, there are difficulties concerned by family members that they might be taken to be, someone who just wants to, engineer the death of an elderly relative. But there are, I think the reassurance there is the law is extremely strict, and we as assessors are very able to detect coercion. So knowing that and using that, if you like, as a protection, I think people should feel entirely able to ask on behalf of family members as well.
Mm-hmm. Just another thought about a tip to broach the conversation. There's been quite a lot in the media in the past couple of months about medical assistance in dying, including a wonderful article in the last Sunday's New York Times about a person in British Columbia who received MAID. And Dr. Google and Dr. Newspaper and Dr. Magazine. Take an article into your doctor and say, you know, do you know about this? You know, have you heard about this? What can you tell me about this? And again, some doctors really like it when their patients bring in information or get questions that they come with from elsewhere, or bring in articles that they're interested in, and others don't. But you know, you'll know your doctor and whether or not they would be open to receiving that. But that's a good icebreaker.
And the bottom line is, don't be put off. Don't not ask because you're worried about how your doctor will feel about it. Frankly, it's unimportant how your doctor feels about it. It's how you and your family feel about it that matters.
Mm-hmm.
Thank you, very helpful. Okay, moving along. So the next few questions are about the procedure itself. We hear a lot about, you know, what the law means and eligibility, but what it actually looks like, you know, for a patient who decides to move forward with an assisted death. So in Canada, there are two options, as many of us know. You can either get an IV with the medication, or you can take an oral substance to access MAID. So can you describe the differences between the two? Also, there's been reports that very few people choose the oral option, and why that might be.
So the difference between the two, I mean, they're both obviously designed to do the same thing, but they do it with quite a different time frame. So the IV, generally speaking, from the beginning of the first injection to the time that death is declared to have happened, is usually somewhere between 10 and 20 minutes. It's a relatively short procedure. I would stress that the person receiving the medically assisted death is aware of only the first 30 seconds or so before they go to sleep from the first drug. The oral can take much longer. It can take up to 2 hours or more. And in some provinces, the doctor is actually required to stay with the patients until death has occurred. And that obviously means that many doctors are not willing to actually provide the oral route. And some hospitals similarly will not do that. I think why most people choose the IV route is that it is quick. The uncertainty is not there. There's also reports of the oral preparations depending on which combination, because it isn't a set combination. It depends on province to province, and even in doctor to doctor. There's no law that says what the combination of drugs has to be. But it can burn. There are also difficulties with swallowing. You've got to swallow a reasonably large quantity within a relatively short period of, say, 3 or 4 minutes, and that can be difficult.
It's bad tasting medicine too.
Yes, absolutely. So it's just unpopular because it's got a number of things wrong with it. Now, of course, in the States, it's only the oral preparation. There is no IV, and I think one of the confusing things that people read is and say that lots of people are given prescriptions in the United States but then don't go through with it. That's because it's the oral preparation, whereas relatively few people, having decided to have a medically assisted death in Canada, decide against at the last moment.
And people have to consent at the last moment. One of the last questions we ask is, are you sure you want this today, and are you sure you want this now? So that people do have an opportunity to change their mind and to back out at any point along the way, and it's not a problem. But another answer to the question of why do so few people choose the oral option, I think it's also partly because so few physicians will actually offer the oral option. I discuss it with my patients. I say there are two routes, IV and oral, and I'm very upfront about my bias in favor of the IV route, in part because it is so quick, but it's also because it's so certain. And the oral medications that we have available, I'm just not convinced are certain enough, and I don't want to put my patients and their families through that kind of suffering. There are some oral medications in the world that would be better, but we don't have access to them here, at least not yet. And so perhaps when that does come, and we have oral medications that are more readily absorbed and more predictable, then we might see more of the oral route being used.
Even in Holland, and Chantal referenced the better oral medications preparations, and Holland is one of the places where they're available. Even there, though, only 5% or fewer patients choose the oral route, the IV is much more popular.
Thank you for the information. Okay. This one is about any adverse reactions associated with the drugs used, and I guess we can talk about the IV drugs just because they're the most popular, of course. So this supporter has a hospice in their community who is opting out of allowing MAID on site because they don't think they could handle any adverse reactions that may arise if something goes wrong with the IV medication. Have you experienced this yourself? Do you know if adverse reactions are common with the drugs used? If so, how would you handle that? And then the third follow-up question is there anyone who's tracking that sort of thing? Is there a national or a provincial body that's keeping track of whether, you know, there's situations where the medications might cause issues?
I have never heard of any significant adverse reactions to the medications. I mean, the medications are designed to be lethal and to bring about death, and they do that, and they do it very effectively, very, very safely, very easily, and with very little discomfort. So I'm not sure why a hospice would refuse to provide MAID on those grounds. And is there a system in place to track information like this? Not that I'm aware of, though it certainly would be a good idea, and it would be nice to know which hospices, which hospitals, which healthcare facilities that patients live in will provide MAID and which ones won't, and that also is not readily accessible information.
I have to say, I totally agree with Chantal that, I mean, as for adverse, I mean, I think it's important to distinguish between adverse reactions to the drugs and misadventure in terms of things going wrong with the procedure. In terms of adverse reactions to the drugs, the only one that can sometimes cause a problem is the drug which is not always given because of the possibility of an adverse reaction, but is still given most frequently by most doctors to put the patient to sleep in the first place, and that's the one, that's a drug called midazolam. And it can cause, what doctors call it, paradoxical agitation. In other words, expecting the person to fall asleep, instead they actually become agitated. It's very rare, and the treatment is to simply move to the drug propofol, usually, which causes the patient to go into coma, which is, you know, that's the main drug of the procedure. There are things that can go wrong if, for example, the intravenous line is not actually in a vein, then the person won't be affected by the drugs, or at least not quickly enough. And it's possible that the hospice is imagining that this might be part of the problem. However, it's, again, not common. If it did happen, then transfer to a hospital. Well, the first thing to do would be to try and put another one in. But if eventually that doesn't work, then you could transfer the patient to a hospital. I have to say, without any evidence, this has the feeling of a place that doesn't want to allow medical assistance in dying, but would prefer to have some nice, neat, medical-sounding reason for not doing so. And saying that it's because of possible medical problems sounds better than we don't like it, or we don't feel comfortable, or we haven't got round to training our staff yet. As far as a system in place to track the information, Chantal's right. You know, there isn't currently. The federal government is looking at ways of actually monitoring medical assistance in dying, getting better data, and I suspect that this would be one of the things that they would want to know about.
Great. And just looping back to what Chantal said, I appreciate you both clearing up the drug questions, but Chantal mentioned that there are a lot of gaps in place right now in terms of who's providing and who's not. And we do have the Shine a Light program, which I'm sure many of you on the call are involved in, so we're trying to get that information. And in a lot of provinces, it's not as simple as you know, contacting the ministry and getting a list. A lot of ministries aren't providing that information, so it is up to individuals like our supporters to go out and hunt down that information. So they're not making it all that easy on us to find out the information we need in terms of what's going on in each community. So we appreciate anyone who's involved with the Shine a Light project. And if you're not already and you're interested, there is info on the website about that too. Okay. All right, so if I want to access MAID, can I get my assessments and request form taken care of ahead of time? How far in advance could I apply?
I think it depends on what you mean by ahead of time. If you're thinking, if you have an illness that is ultimately going to be lethal and you are pretty sure that you want MAID, I think the sooner in the process you start to have the conversation about it, the better. Whether the formal assessments should be done at the time that you initiate that conversation or not is a question to be discussed with the doctor. In terms of how far in advance you can apply, you have to be eligible in order to be deemed eligible. You have to meet all the criteria at the time of the assessment. So if you meet all of those criteria, including the intolerable suffering and the foreseeable death, and you are approved for MAID, and maybe the question is, how long can I keep that approval before I have to reapply? And the answer to that question is nobody really knows. Most of us who are, follow patients over a period of time would probably say within 3 to 6 months, and then if not a formal full assessment, a reassessment just to confirm the eligibility criteria are met at the time that someone wants to access the MAID procedure. So the short answer is we don't really know. The longer answer is a bit more complicated. But again, the sooner you start talking about it and sooner you start having those conversations with family and with physicians, the sooner you can find out about the eligibility and then take advantage of it.
The rules regarding the order of request form and assessments do actually vary province to province. I believe that in Ontario, a patient is not able to do a formal request until a first assessment has been done, whereas in BC that's not the case. Patient can put in a formal request as long as they've received enough information about their condition and the options from somebody who's not an assessor. Yeah, the question of how long is the finding of eligibility valid? We don't know, and Chantal has quite rightly said that most providers would say somewhere between 3 to 6 months. But the most important thing is that you should be you should be asking and seeking information early. Don't leave it to the last minute, because that makes things more difficult. And there's also, I think we'll be dealing with this later, the issue of loss of capacity, which is an awful end result, which is where somebody who's wanted a medically assisted death loses the mental capacity to consent to it, and then they've lost that opportunity. But I suspect we'll do that in more depth in a bit.
Yeah. The other thing I would add is that one of the criteria for eligibility is that your suffering has to be intolerable. And if you say your suffering is intolerable and you are approved for MAID and then choose not to take advantage of it, then the question becomes, was the suffering really intolerable? In my experience, I would say yes, I think the suffering is intolerable, but someone has found a way to tolerate it. And that's, we can live with an intolerable pain. Many people do for long periods of time. And what I found also in doing assessments is that sometimes just having the possibility of MAID, knowing that they can access it, gives people a bit of relief. And then they can decide, okay, now that I know that I can, I actually don't want it right now, but maybe I will in a few weeks or a few months. And that's fine. They just keep in touch with me, and I keep in touch with them and follow up and check in and reassess as necessary. And I think most physicians are finding that the relief factor of just knowing that it's possible makes a difference in terms of time.
Yes, my colleague and I, who run a referral service in our part of Vancouver Island, call it having it in the back pocket. It's incredibly powerful. It's incredibly therapeutic. It's almost like the sleeping tablet that works sitting in the bottle on the nightstand.
Yeah.
Okay, now this is a question about what actually happens in the room when you're there for someone accessing an assisted death. What's it like to be there? How has the experience affected you as a physician and just as a person?
It's one of the most moving experiences that I've had as a physician. There's an enormous sense of privilege to be involved in that, and to have been asked by somebody to be part of this very last stage of their lives. I was worried at the beginning, before I'd actually provided a medically assisted death, that, well, first of all, that I wouldn't carry out the procedure well. So there's the anxiety of not doing one's job properly. But it's a relatively simple thing to do, and so that you know, one still is extremely careful, obviously, to do everything really well. But to be with a family at that point is quite remarkable. My colleague, we gave a talk to a group of about 100 people. It was in a church, but it wasn't a church meeting. And she said that one of the most wonderful things about medical assistance in dying is that the last thing the person sees as they close their eyes forever is the faces and smiles of all the people who love them most. And you feel that. Of course, there are sometimes other circumstances where it is an even sadder occasion than most deaths are, or where the person is all alone, and it's just you and them, and the nurse who's perhaps helping one. But generally speaking, you are with somebody who has chosen to take charge, to face death on their own terms, and to gather to them and with them the people they want to be part of that. So yes, when one walked in, the person was alive, and at the end they're not. But the sense of having done the right thing for somebody, and the gratitude and thanks that one receives from the person, the fellow I was with the last time I provided a medically assisted death, he told his family that I was his new best buddy because I was doing exactly what he wanted. But that sense of doing the right thing, and then the gratitude and thanks from the family, to be honest, I mean, I've been involved in providing terminal care, palliative care for a very long time. I've got a very elderly practice, but I haven't been in, so the best deaths that I have been involved in have been medically assisted deaths.
I agree with Jonathan. It's been an incredibly moving experience. From the time I first meet a patient and initiate the assessment, right to the finishing the last injection of the medication. I mean, it is such a privilege to be part of people's lives, to be welcomed into their lives and their homes and their families at this time, that they trust us with the information, with their lives, with their wishes, and it certainly has affected me profoundly, and only in positive ways. You know, like I said before, I have a long-standing interest in choice in healthcare and belief in the right to assisted death, and so when it became legal, I thought, okay, what am I going to do? That if I can do it, then I have to do it. And I wasn't sure. I did a lot of exploring and a lot of research and soul searching, and spoke with my family, and just thought about it a lot before making the decision to see a first patient, and have not looked back since then. It's because, again, it's been such a profound and moving experience, and the quality of care that we can give to people at such an important times of their lives, I think there's nothing better than that.
Thank you both. I think we hear so much about what's going on, but hearing directly from providers and people who, you know, have that very unique opportunity to be with someone and help them, you know, access the death that they want, and like you said, have the people who mean the most with them, and have them sort of tailor things so that their final day is exactly what they want it to be, is so special. So hearing that, you know, straight from the two of you, I think will be is quite meaningful for everyone on the call as well. So thank you for sharing that. Okay, so we're moving on to support and resources, and this is, you know, is there any support for families before the death, for, you know, people who are helping, you know, family members go through the assessment process and the paperwork and all of that stuff, and also afterwards, once everything's over and the patient is gone, where do you refer patients typically, or sorry, family members typically after the death is over?
I'm not aware of there being any support for either before or after a MAID death experience, except dying with dignity. You know, that's the patients and families that I've seen and worked with have had precious little support from anywhere else, and they don't know where to go. And I always offer to provide support to families. I'll meet with anybody, family members, friends, anybody the patient wants me to meet with. I'm happy to meet with them and answer questions, discuss things, walk them through it before. And I'm also very happy to meet with any family and friends afterwards who might want to have a bit of counseling or just to decompress and go through the procedure or express their thoughts, feelings, whatever. But I don't think institutionally there's anything that I'm aware of that is provided either through public health or through the Ontario government or any other official body.
I think it very much depends on where you live. There certainly isn't anything which is specifically for families who've been affected by a medically assisted death. There may be pamphlets, as there are so many, pamphlets about all sorts of things, cancer treatment and heart treatment and so forth. And so it may be that in some areas there are pamphlets that can help and guide people to more generic resources. Certainly in our area, we do have a hospice society that does provide bereavement counselling. And the bereavement associated with a medically assisted death is really no different, although there are elements which are different, but overall one still lost a loved family member. There is also, and Kelsey, I'm not quite sure how this would be best accessed, whether I should just try and give an indication of how to see it now, or whether there's some way of people accessing it through Dying with Dignity. But there is an extremely good 35-minute video on YouTube, which was created by the husband of my colleague's first medically assisted death. And it really does help people understand the sorts of challenges that a medically assisted death poses to both the patient and also families. I remember, I can't remember if it comes in the video itself or whether he just said it in the talk, but this man said that one of the things was knowing that he opened the fridge and took out a carton of milk, and the best before date was after his wife's planned death. That was really quite challenging for him, and of course most people don't know when the date or the hour of their death, and people who have chosen a medically assisted death do. So this video is very helpful. I mean, I'll mention it now, but if Kelsey, if there's a way of letting people access it, it's called Saying Goodbye for the Last Time, and the patient's name, and it was it's open, it was Storm. That was her first name, Storm, as in thunder, Miller, M-I-L-L-E-R. So if you went to YouTube and looked up Saying Goodbye for the Last Time, Storm Miller, you would find this video. I can strongly, very strongly recommend it.
Thanks, Jonathan. And we'll pull up that video too. So if anyone struggles to find it online, just let us know, and we're happy to forward that along. But I think you bring up a really great point with assisted death being so peaceful and beautiful and patients having control, but it is so different because there is that date set, and you're grieving the person before they're gone, which you do with other deaths that you know are coming, but having that date in mind, I think, would be that extra layer for people to process. So it is a bit different. And
I remember one of my first patients talking about that. He repeated it a number of times. It was quite startling for him to recognize, I know the date and I know the time of my death, and how strange is that? Mm-hmm. And he really puzzled about that. And on the day of his procedure, I had to arrange for 2 volunteers to come and witness his final consent form, and he was talking about this in front of them, and they, volunteers, that people who obviously support medically assisted death, but not medical people, and they were profoundly moved by hearing him talk about that, and he was comfortable to talk about it with all of us in the room at that time. And so those kinds of things, I mean, it's again, it's a real privilege to be part of that and to hear that and to help people to come to terms with the decisions that they've made and what's happening to them.
Sure. And to echo Jonathan, Nino Sakopet, our personal support and advocacy manager here in Toronto, is available to speak with anyone, patients or families, before or after the death has occurred, so he's always available. And in some of our chapters across the country, there's some support in some of those areas too, so feel free to reach out to us if you need to talk to anyone. Okay, the next chunk of questions is about access. So why does the government permit faith-based institutions to opt out of providing MAID in their facilities when they are receiving public funds?
My local hospital is Catholic. It's the only hospital in our community. The nearest hospital apart from it is an hour north, and the next nearest is an hour and a half south. And the hospice, we're lucky enough to have a hospice, unfortunately is within the Catholic hospital. It is, of course, entirely right that an individual nurse or physician should not have to be involved in medical assistance in dying if they don't wish to or cannot for reasons of conscience. But it is not right that faith-based institutions opt out. Now, in Ontario, it is actually now legal. It's actually expressly legal for hospitals to back out. A bill was passed just in the last couple of weeks, I think, Chantal. In the rest of Canada, it relies on various agreements that have occurred between hospitals, healthcare providers, and the province's Ministry of Health. In the case of BC, it's an agreement which is well over 20 years old, and of course actually had to do with abortion, not medical assistance in dying, which didn't exist. So with the exception of Ontario, which is because there's a law that says they can, in the other provinces it's just agreement, and I think lack of political will to actually require all publicly funded places where it would be appropriate otherwise to provide a medically assisted death, places with beds basically. It's because no government has had the courage to say that they should. The likelihood is that it's going to take a court case, probably one that will go all the way to the Supreme Court, to determine whether or not this is something which these institutions can do.
So the answer to the question, why, it's a good question. I don't know why. I find it unconscionable that the government does permit faith-based institutions that receive public funds to not participate and provide a legal medical service, period.
And the answer probably is that these facilities have very powerful organizations behind them. Like in my case, but it isn't only. In my case, it's the Catholic Church. In other areas of Vancouver Island, it's Baptists. In other areas, Jewish hospitals. So there are big, strong, powerful lobbying groups behind these facilities. And governments don't have the courage to take them on. And in some cases, I think the Canadian public is well ahead of both the politicians and physicians and nurses in terms of accepting medical assistance in dying.
All right. And just to echo everything, Dying with Dignity Canada's official position also is that we believe that all hospitals, hospices, long-term care homes receiving public funds should allow assisted death on site. So that's something we'd like to see as well. It's going to be a long fight probably, but we're working on trying to have as consistent access across the country as we can. Is it difficult to have a MAID death in your own home? Are there any special considerations to keep in mind if you do choose to have a death at home?
I don't think it is difficult to have a MAID death at home. I mean, there are certainly providers like myself who I almost only provide in people's homes, and so we go and set up and do what needs to be done in the home. In terms of special considerations, some patients have actually said they're concerned about how their families will feel being in the home afterwards, so it's certainly a conversation to have. husbands, wives who don't want their partners to have to live on if they're uncomfortable with knowing that their loved one died at home. So there are questions and things to think about for sure and to discuss with family. But in terms of the procedure itself, it's very easy to do at home.
Similarly, I have in fact provided almost all the medically assisted deaths that I've done in patients' homes. In other countries, I mean, it depends where you are in Canada. Where we are on Vancouver Island, 65% of all medically assisted deaths are done at home. I think in areas of Ontario, it's 65% are done in facilities. 50-50. Yeah, 50-50, right, okay. The special considerations are, as Chantal has said, then there are the issues that people have talked about, the choreography of a medically assisted death, and it's little things like, make sure the phones are turned off and that your cell phone is on vibrate, and the little things to make sure that you're not disturbed. I think the other thing is it's a very good idea to make sure that anybody who is going to be there with you is themselves comfortable with a medically assisted death. It is important to actually check that. Some people may feel pressured or that it's their duty to attend, even though they themselves are uncomfortable with it. And I have been involved in a couple of cases where that hasn't been true, and the anxiety and upset that the person who wasn't comfortable felt and exhibited actually can interfere with the peacefulness of the medically assisted death. The other thing is that I would say, in terms of special considerations, this is your, if we're talking about your own medical assisted death, this is your day. I mean, this, apart from the actual simple act of the physician getting the final consent and usually giving the IV drugs, the rest of it is how you want to do it. It can be quiet, it can be ceremonial, it can be a party. The special considerations are your special considerations.
And it's asking for what you want, getting clear about that, and then asking for what you want. I guess in terms of other special considerations, sometimes patients have had some concerns about having a death at home because of the public visibility when the funeral home comes to remove the body. And so sometimes I know providers who have gone to patients' homes in the middle of the night to do it, to try to minimize the public exposure, those kinds of things. So if you have concerns about that, it's worthwhile to talk to the doctor about it and see what can be done to try to work around whatever some of those concerns are. And just something else I'll bring up, and I feel a little bit uncomfortable even raising it, but I know on some purchase and sale documents for house sales, some people are starting to add questions that, has there ever been a death in the home? And so it's something to think about. There may be some potential buyers of a home who, if they know that a death, whether it was an assisted death or another death, would not want to buy the home, and that so it can affect potentially property values, and it's something to think about.
I had never thought of that, and I have to say I'm not sure that many of my patients would have decided against on the basis of that. But I take the point. There's another one actually. Sorry.
Just informed consent, so just being aware of, there are some risks.
There's one other thing which I'll just bring up, because I am often asked, is people worry that, if it's going to be done at home, that there's going to be an outpouring of fluid from the patient. I have never seen that. It is a worry that people have. It just doesn't seem to happen.
Great, good to know. Thank you, everyone. Yeah. Okay, so that is it for the questions I had prepared on the slides. There are a few extra. There's some that are coming in now, and a couple extra that didn't quite make it to the slides, but that we can go over now because we have a bit of time left. So there was a question about organ donation, or whether it's donating individual organs or donating your whole body to a medical school, for instance. If someone accesses an assisted death, are they still able to donate their organs?
The answer is yes. I think it depends very much on the nature of the illness, of course, and there are definitely then special considerations, because for most organ donations. They need to, the organs need to be taken from the body quickly, and therefore it is usually necessary for the death to take place in a hospital. Not always, and it would be down to the physicians involved to find out what the circumstances were. There were some quite lurid stories about, about how shocking it is that doctors were harvesting organs from medically assisted deaths of patients. But the point, of course, is that there's an enormous lack of organs. People have the right to do whatever they wish to do with their organs. If they wish to donate, then they should be assisted in doing that. So it's really no different from an organ donation from any other person whose death has occurred.
In Ontario, there's something called, I think it's the Ontario Trillium Gift of Life program, and some hospitals require anybody who dies in hospital, the family has to be asked, or the patient has to be asked, if they're willing to donate their organs, and that includes patients for MAID. And anybody who wants to, has had a long history of wanting to donate organs, certainly speak with the physician and set up some meetings ahead of time to try to put that in place if that's what you want.
Great. Now, we had a question earlier about support for the patients or their families when they know what's coming, and also how to deal with it afterwards. But as physicians and as providers, what do you do for self-care, and what support do you have as someone who is going through this process on the other side?
Well, I think one of the professional supports that we have is colleagues across the country through an organization called Canadian Association of MAID Assessors and Providers, and we have a listserv that we communicate on quite regularly, and there's a tremendous amount of support and peer education that goes on there. I have any number of physicians I can call if I'm having any concerns, or if I have feelings that I want to process with somebody that knows exactly what I'm going through and has seen what I've seen. But also, just good self-care. I think in medicine, physicians need to practice good self-care in general, and having that various mechanisms and strategies in place over the course of one's career is very, very important. And being open and willing to talk about it is very helpful too.
So even the experienced team of myself and my colleague, and sometimes with the addition of a nurse who's been working with us, we are always careful to go for coffee afterwards. We make sure that we don't book something afterwards that will get in the way of that. And we're particularly keen to do that if there's a new member of the team, what we're often seeing is that family doctors wish to assist in the medically assisted death on the day so that they can learn about the procedure and then start to provide it themselves for their own patients. And so we're very keen to actually, after a procedure, go and have a cup of coffee together and talk about how it went, how it might have been done better, how we might do things slightly differently, something that arose. But usually, to be honest, we sit and say how lovely it was, and how well everything went, and how fortunately we are that we live in a country where this is legal, and how privileged we feel to be doing it.
Thank you. And this is a question about eligibility and going through the assessment process. So if someone met with physicians, went through the assessments, and the two doctors said that they were ineligible, could that patient go speak to another physician and get assessed by somebody else? Could they potentially even go to another province to get that done if they couldn't find support in their own province?
The answer is, I think, yes. There's nothing in the law that says that the patient can't keep trying until they find two assessors who say that they are eligible. I think if you keep being found ineligible, then the likelihood is that you are ineligible. There is patchiness, a term Chantal used earlier, about medical assistance in dying generally in terms of access. And because of things like uncertainty around the meaning of reasonably foreseeable or advanced state of decline, then in some areas you might find physicians less willing to find a person eligible, where otherwise you might find somebody who says, no, in fact you are. So I wouldn't say that you can't try again, but I think if you are, keep coming up against, no, then there's a problem. And you probably know what it is because the doctor will have said so. And it's usually, it's usually going to be to do with reasonably foreseeable, or the intolerable suffering bit. The law makes it clear that it has to be intolerable suffering from the viewpoint of the patient. But one of our jobs is to assess and make sure that there aren't other reasons getting in the way of the patient finding their pain more tolerable. So we need to make sure that depression, for example, a depression that could lift through treatment, isn't what's causing the suffering to be intolerable. Or other mental health issues which can lead to a person making what to the doctor is an inappropriate assessment that their life is intolerable. I know that sounds a little bit sort of woolly, but doctors aren't just machines. We're not there just to say, I hear you say it's intolerable and agree. It is from the viewpoint of the patient, but we still have to make an assessment as to whether that is an appropriate response by the patient to what is going on.
Great, thank you. So we discussed earlier in the webinar that there are some people who could only qualify for an assisted death if the option for an advanced request was legal at this point in time, which it's not in this country. So unfortunately, that's not available for people right now. So this question is, if I wanted an assisted death sometime in the future, and I put that in my advanced care plan or my advanced directive today, and then at a later date, advanced requests were permitted, would me writing that in my document today allow me to access it at a later date, or would there have to be additional pieces in place?
I think that's a question for a lawyer. I'm not sure.
I think the answer is very probably not. If advance requests come in, I mean, if they become legal, then there are going to be very strict rules around them. It isn't something you're going to be able to have just jotted down on a piece of paper and sort of, stuffed in a drawer somewhere, and then your nephew comes along and finds it and goes, oh. There will be very strong rules, very strict rules about it. So I think that's improbable. I'm very hopeful that one day there will be advance requests. I think that there should be very strict rules about that. We should. What I'm about to say, some people may find it a little controversial, but I think that simply allowing medical assistance in dying because somebody has dementia, just that, with no suffering, I don't think that will be appropriate. I don't think anyone will ever see we won't see a law in Canada that allows that. I think it'll be a combination of intolerable suffering and an advanced request with lots of rules about how that's made, when it's agreed by a panel of the type that already exists in terms of assessment, agreeing that yes, this person with dementia has intolerable suffering. There isn't intolerable suffering. Dementia alone, and I would stress, I'm speaking as an individual physician here, I think that without intolerable suffering, a diagnosis of dementia alone should not be a reason for a medically assisted death.
Chantal, anything to add?
No, I think that's good. I mean, but again, I think because an advanced care plan, generally advanced directives are legal documents that the lawyers are going to have to weigh in and answer some of these questions too when that time comes.
Yeah.
Yeah, it's complicated for sure, and
Mhm.
I think
So
we have a lot.
having, I think Dying with Dignity's advanced care planning kit helps people to think about what it is that they might want. And certainly if you have a sense of what your suffering is and what you anticipate your suffering will be. Obviously, none of us can perfectly predict how we're going to feel when we get to a certain stage of life, but having the kinds of questions that are asked in the advanced care plan that Dying with Dignity has, and the University of Toronto Centre for Bioethics also has a very good advanced care planning document, which helps you to think about what are the kinds of things that I might face at end of life, and what kinds of things would I want, what kinds of things would I not want. And again, I encourage people, all the people in my life, whether patients, family, friends, to look at these documents, fill out the documents, and share them with the people that are going to be potentially looking after them, so that the people who might be in a position to make decisions about your life when that time comes really have a good understanding of what you want. Because when you designate someone to be your power of attorney for personal care, that person is not to do what they would want. They're obligated to do what you would want, and if they don't know what you would want, they're in a really difficult position. So again, the more you can elucidate what it is that you do want, and the more you can share that with the people who are going to be having to make those decisions, the better it will be.
Mm-hmm. Okay, thank you. We have time for a couple more questions. So you mentioned earlier that you have to consent at the time of your death, and one of the final things you do is ask the patient, are you sure? Do you want to move forward today? Is this something you still want? So if that person says, no, I've changed my mind, I don't want to die today, can they still access MAID at a later date?
Yes, absolutely. And I maintain a relationship with the patients, and I say, you can choose to say no at any time, and when you decide you want me to come back, I will come back and we will revisit it.
Yes, I mean, it would depend very much on the circumstances of that. I mean, if they had maintained a wish to have a medically assisted death, been very clear right up to the very last moment, but then for whatever reason that day just didn't work for them, because they felt, well, actually I could manage another couple of weeks. Of course, I think there can be circumstances where it calls into question whether or not they had really considered it. So I think rather than a blanket, yes, anyone who has done that can have a medically assisted death pretty much as soon afterwards as they want. It would require, this is something that we should be very careful about. And so we should always be alert to the possibility of needing to reassess the situation.
I definitely think there should be an ongoing conversation. So, whether at that time or at a later time, to have another appointment. And so let's talk about what happened and what your thinking is and what you were feeling and what was going on for you. So again, as a physician, I would want to try to understand that as much as possible, and also help the patient understand. Can imagine that they might be very puzzled, especially if they had been very clear and deliberate and sure that they wanted it, and then get to the moment and discover, no, I can't do this, I don't want to do this. I would want to help them understand and what had happened for them, so that they would have a clear mind going forward with whatever they chose.
Mm-hmm. Sure, and that seems to be stressing sort of what the first question was about too, keeping that dialogue flowing between the patient and the physician, and making sure everyone is able to say, exactly what they're feeling, no matter what they choose, or how everything plays out. The next question is about physicians, and this person has heard that there's been a number of doctors who signed up to become MAID providers but have since dropped off. And I think that this person may be referring to a news article that was here in Ontario, but this could be elsewhere as well. So people who said, yes, I want to move forward, and slowly took their name off the list of MAID providers. So do you have any comments on that, why you think this may be happening?
The opponents of medically assisted death have suggested that the reason for this is that the doctors have been adversely affected by what they've done, if you like, have regretted their decision and feel it was, and now feel it was the wrong thing to do. I think in very few cases that may be true, but I think it's actually rather unlikely. Unfortunately, the main reason is that providing a medically assisted death is incredibly time-consuming. It takes an awful lot of time to do an assessment well. I mean, Chantal has talked about, the way she stays in contact with the patient. We have lots of phone calls to colleagues, phone calls to the patient, phone calls to the patient's family. We don't, if the patient is happy for us to speak to a family member, we usually would want to do so directly to help that family member, through whatever issues they have. There's very, very little, and the other thing is the paperwork is extraordinary. I think particularly in Ontario,
Yes.
actually, it does again vary province by province. This is work which takes a great deal of time. And many doctors are finding that because of the lack of funding, proper funding for medical assistance in dying, both in terms of, frankly, remuneration for physicians, but there aren't properly funded systems in place to assist the physicians, that in fact their lives are very much easier if they just stay in their practices and do their ordinary family physician or internal medicine or anesthesiology work. It's not draining from the point of view of emotionally, and we've said it's a very positive job to do from the point of view of emotions, but it's a very difficult job from a time point of view. And I think these doctors have simply said, I can't make this work. I'm going to have to go back to what I was, to just exclusively doing what I was doing before. Chantal, I don't know if you feel that that's an adequate answer.
I actually don't know anybody who has stopped, and I've only heard theoretical reports of why people have stopped. And I know a number of people have delisted from the registry in Ontario, but the registry isn't telling us why. So I don't really know.
Yeah, I am basing mine on knowledge of individual physicians who simply cannot continue because life is just made too difficult by the system and the lack of support and funding.
I can certainly see that. I think those of us who are providing MAID are making those commitments in terms of time and energy and taking that time from our practices and dedicating a certain amount of time to providing MAID and all that goes along with it. But it's not easy to fit it all in, that's for sure.
Yes, and time, not just time from practice, but time from families too. It eats into both sectors of one's life in terms of time.
Thank you for that insight. I think one final question that maybe we'll end everything on today is we've been talking a little bit about the procedure and what it looks like, but someone was wondering if there's a situation where you're going into a home to provide an assisted death, just what sorts of we discussed ceremony and that sort of thing, and people choosing deaths that are meaningful for them and that makes sense for them as an individual. If there's anything you've seen that has been especially meaningful or memorable that you'd be willing to share, just those beautiful moments that make what you do so special and so important.
For me, it's the little things, actually, very often. It's just the interactions between the patient and their family. It's the reminiscing, the do you remembers, the sort of the wake where the person is still present, still alive, chatting about their life, and all the reminiscences that go on. That is, it's very important and very meaningful, and every family does it in a slightly different way. It's the goodbyes that one sees taking place. As far as the ceremonies are concerned, yes, having people doing readings from sacred books or from just favorite poems. And for me, it was being handed a beautiful rose as I left one family as thanks for what I had taken part in.
I certainly had the range of a celebration of the person's life, and I remember walking into one place and the family was all gathered there and some close friends, and a spiritual person was leading a ceremony, and I thought, okay, I'll just stay outside the room and wait just quietly, and they wanted me to come in and join in with them, it was an amazing experience. It was not something I had ever participated in before, and here I was with these people at a very significant time in all of their lives, and a stranger really to most of them being welcomed into it. So that was quite moving. And I've also experienced with other families where there's a lot of conflicted emotions, and people have difficulty saying goodbye to the person who is choosing to die, and it's emotionally painful. So it's quite poignant to be with them while they're saying the last words and hearing the last words from the person who is dying, and to see their grief and see their pain and see their suffering during all of that as well. And then to spend some time with them afterwards to just keep them company while they're feeling whatever it is that they're feeling. So the whole range from a kind of celebratory to very, very sad and deeply grieving.
I do remember one particular guy who was very pleased that I had found him eligible and he was going to have a medically assisted death. And he was a retired Marine captain and used to sort of taking charge, but also I'm very keen on the idea of sort of transportation and so forth. And when I turned up, he handed me his ticket, just as if I went onto a train or a boat or something like that, with my boarding pass. He handed me a ticket and it had his name on it and the date and the time and a picture of the Starship Enterprise and ticket to the stars written on the top. It seems odd, but actually this was his celebration of being able to leave his painful, distressed, very short of breath reality to something else as he saw it.
Thank you. That's wonderful, and thank you both for sharing those stories with us. I think that will conclude the webinar for today. Chantal and Jonathan, thank you both for taking the time out of your day to join us, and I think you provided such a unique opportunity for everyone, and on behalf of everyone on the call, I'm sure that they'd agree that this has been very, very just very interesting and a great way to learn more about what you're dealing with as physicians, and also what patients are facing too across the country. So thank you both for that. For everyone on the call, thank you for joining. We appreciate you sending your questions ahead of time, as well as the ones that you typed into the sidebar. I know there's some there that we didn't quite get to. If you did type a question into the sidebar there, GoToWebinar will save those for us, so myself or someone else will follow up with you through email and try to get your questions answered and get any resources to you that might be helpful. As mentioned earlier, we will be sending out a survey tomorrow. Please do share your opinions with us and let us know what you thought of the webinar. As you may know, this is part of our End in Mind webinar series, which we will be continuing hopefully for many years, and we'd love to hear more about any suggestions you have for future webinars as well. So please do take a few moments to fill that out tomorrow and in the next few days. And again, if you think of any questions, feel free to reach out to us. We're happy to answer anything that may come up to help you out and get you the info that might be helpful. And I think that wraps it up for today. Again, thank you all for joining us, and we will be in touch soon. Have a great night.
Thank you.